So, good afternoon, everybody. Welcome to our Integrated Care Partnership meeting. Let me remind you before we start that this meeting is being live streamed, which means that there will be members of the public watching us and taking in our work. I think before I begin with the welcoming introductions, I'm just going to go around the room and ask each person to introduce themselves for the benefit of those people in the room, but also for the benefit of those people watching us. And I'm going to start with you, please, Karen. So just your name and job title, I think.
Thank you. Good afternoon. My name's Karen Pavey and I'm an Executive Director for people at North Lincolnshire Council, representing both Councillor Richard Hannigan and Alison Barker. Thank you.
Linda Chambers, Councillor from Hull, Chair of Hull's Health and Wellbeing Board.
Thank you.
Hello, I'm Jane Hazelgrave and I'm the Acting Chief Operating Officer at the Humber North Yorkshire ICP.
Thank you.
Good afternoon, I'm Wendy Balmain, I'm the Place Director for North Yorkshire.
Thank you.
Hello, Gary Sainty, Head of VCSE for Humber North Yorkshire Health and Care Partnership.
Thank you.
Hi, I'm Nikki Lower, I'm the Head of Corporate Affairs and System Support.
Thank you.
Hello, I'm Mike Napier, Director of Governance and Board Secretary for the ICB.
Good afternoon, everybody. Karina Ellis, Executive Director of Corporate Affairs for the ICB.
Sue Symington, I'm the Chair of the ICP.
Councillor Jonathan Owen, East Riding of Yorkshire Council, Chair of our Health and Wellbeing Board, and recently readmitted to our Cabinet as Portfolio Holder for Adult Social Care and Health.
I'll follow that. Good afternoon, everybody. Pete Thorpe, Executive Director for Strategy with the ICB.
Hi, my name's Helen Kenyon. I'm the North East Lincolnshire Place Director.
Hi, I'm Charlie Jeffrey, Vice Chancellor at the University of York and Chair of the Futures Group of the ICP.
Hi, I'm Sarah Coltman-Lovell. I'm the Place Director for York with the York Health and Care Partnership and ICB.
Good afternoon, everyone. My name is Dr. Ramratan, Brickchand Ramratan. I'm the Exec Director for Adult and Health in East Riding.
Good afternoon, Councillor Stan Shreve. I'm Deputy Leader of North East Lincolnshire Council, Portfolio Holder for Health, Wellbeing and Adult Social Care, and Chairman of the Health and Wellbeing Board.
Jake Abbas, I'm Deputy Director for Population Health Intelligence at the ICB.
Hi, Jeff Lewis. I'm the Consultant Public Health for the ICB.
Thank you. And with us virtually is Stephen Eames. Stephen, do you want to just introduce yourself? Oops, you're on mute.
Port out, yes. Stephen Eames, Chief Exec of the Integrated Care Board. Sorry, I can't be with you.
And Michael?
Thanks to Councillor Michael Harrison. I'm the Executive Member for Health and Adult Services, including Public Health on North Yorkshire Council, and Chair the North Yorkshire Health and Wellbeing Board.
Thank you very much indeed. All familiar faces around the table, except I think Brickchand, we do need to make a very warm welcome to you. We're very pleased that you're here with us and we look forward to working with you as we progress. So welcome to the meeting. I do have a number of apologies. I've taken apologies from Nigel Wells, Erica Daly, Alex Seal, Simon Cox, Amanda Bloor, Louise Wallace, Dave Tucker and Alan Menzies. And I think we've got some people deputising for one another around the table, haven't we? Can I ask, please, are there any declarations of interest anyone needs to make before we go into the agenda? No? And can I just take you to the minutes of our previous meeting? So the minutes are a record of the meeting that we held on the 20th of March. So I'm going to ask first, are these minutes an accurate record of the discussion that we had? Everyone satisfied they're accurate? And are there any matters arising in these minutes which don't appear later on our agenda that anyone wants to raise at this stage? Nothing in respect of the minutes, thank you. We have got a matter arising on our agenda, which is around the progress update on children and young people. And I think in many ways, Charlie, you're going to be providing us with an update from this morning's Futures Group around our work around children and young people. Have I understood that correctly? Is that the update? Yes, no one else is preparing to do anything different. And I don't have any matters of any other business that I'm aware of that we're going to be dealing with at this meeting. Unless there's something people want to raise? No, okay. As you know, Jonathan and I share the chairing of this meeting, so we have an equal distribution of chairing responsibility between the NHS in the form of the Integrated Care Partnership and local authority. And we begin our meetings always with both Jonathan and I providing a brief update on where we're currently at in our own organisations, and in particular I'll attempt to sort of make you aware of where we're at with the Integrated Care Board first. Jonathan clearly sits on the board. I've got a little list I'm going to go through, but I'm very pleased that Stephen Eames, the Chief Executive, is here. So I'll go through my little list, and Stephen may want to add some additional matters. It's very important to us, to both Jonathan and I, that there is a bridge that exists between the Integrated Care Board and the Integrated Care Partnership, and this is one of the ways that we try and make sure that that bridge exists. So things around for the Integrated Care Board. No one will have missed the fact that we're expecting a general election, and that has made the atmosphere febrile amongst all those of us who work for government. And that colours, in fact, some of what we're doing at the moment. The second thing I want to just advise the Integrated Care Partnership is our regional director, Richard Barker, is retiring at the end of this month. So we want to publicly recognise his commitment and hard work in working for us. But we don't yet know who his successor will be. So while this may seem a little bit academic to you, the regional office of the NHS is our buffer, if you like, between our integrated care system and the NHSE board. So the regional director and the appointment of a regional director is really very important to an integrated care board, an integrated care partnership, and to our system overall. So just so you're minded that that's something that's on the minds of those of us involved in the ICS. We continue to do battle with the here and now, so those things that present as hugely important in the moment, and those things that we know to be of strategic importance in the longer term. And if I was just going to run through a list of those things I think have been particularly on the mind of the Integrated Care Board over the last 3 months since we met, I would include urgency and emergency care performance. I think a great deal of concern around that. A huge amount of money, it is a huge amount of money, but a huge amount of work around closing one financial year, starting another financial year, and ensuring that we're able to have a balanced budget. Jane Hazelgrave is with us this afternoon, and she's nodding. Much of that work was hers, so thank you, Jane. We have to work very hard in our organisation to balance our books, and a number of things have been going on to enable us to do that. That's been an internal pressure. And we've also been looking very closely at how we might better improve and create a strategy for moving forward, a longer term strategy. And things that you won't have avoided in the news would be the significant cyber incident in London, which I understand is now not even close to being resolved, and is seen to be a really huge and major incident, big worry for all of us, along with the junior doctor strike, which you know will be starting tomorrow. And this is the junior doctors away from work now for 5 days. Very, very significant. In terms of our longer term work in the ICB, I think we are keen to develop our approach to start well. Our work around children and young people, and Charlie will talk a little bit about that. And today's focus this morning for our Futures group was around age well. So you'll remember there are 4 key areas around which this ICS coalesces: start well, live well, age well, and die well. So these are our 4 big buckets of work. And 2 long-term pieces of work going on around that. The first around start well, and we're going to hear a little bit more about age well today. I've got one final thing that I want to remind you all of, and that's that we've got our AGM on the 10th of July. And this year we've put our AGM into film format. So you don't have to be at a particular place at a particular time to watch it. The film will be there, but you can watch it hot off the press at 5 o'clock on Wednesday the 10th of July. There'll be some familiar faces in that film, and I'm sure you'll find it most interesting. So let me encourage you all to watch the AGM. Stephen, have I missed anything in particular that you might have wanted to say about what's been preoccupying the ICB over the course of the last 3 months?
No, and I think probably means I don't need to say very much more, actually. So if you were coming to me before the vice chair or the partner chair in Jonathan, just 2 quick things then. In relation to industrial action, the BMA have indicated there is a ballot going on currently around industrial action in relation to general practitioners, and obviously the wider impact on primary care. And in fact, there is, and it's in the public domain now, a list of actions that may be taken actually in the run-up to that or during the course of that ballot taking place, so or concluding. So I mentioned that in addition to what you mentioned about the junior doctors, and I suppose what you draw from that is it's I guess in the priority inbox for the new government after the 4th of July election to address those long-standing issues. The other thing I wanted to mention, and Councillor Harris is on the call, so he may have more insight than I do, but I was privileged to be involved in the appointment of the Chief Executive for the Combined Authority for North Yorkshire and York 2 or 3 weeks ago, and I think it's now public that James Farrer, who is well known, I think, in Yorkshire circles over a number of years, is taking on that role in support of the newly appointed mayor. So I thought it was important just to lodge that, because that's another major step, I think, in the devolution agenda that's going on, and I suspect will pick up pace post the election. So I'll leave it at that for now. Thank you.
Thanks, Stephen. I don't know if anyone's any questions for either Stephen or I. In which case we'll move on. We're on to item 8 for those of you following the agenda. This is our local government partnership report. I'm handing over to Councillor Owen, the Vice Chair.
Thanks very much, Sue. And I always feel these updates are really just read the last minutes and the minutes before, because most of the main issues are very similar. So I will skip very briefly over workforce strategies and workforce, etc. Other than I believe across the region, that's wider than just the ICB, but Yorkshire and Humber, there's a lot of work being done on workforce strategy. And even at local level, I know quite success in attracting staff into the social care sector. A lot of it about trying to promote care and caring and social care as a profession that people should really want to go into and live through the future. So that there is some success there. Delighted to hear from Stephen that James Farrer has been appointed in North Yorkshire and York, because I spent many years on the old North Yorkshire LEP, which was joint with the East Riding, working with James, and a very solid and capable man, and really pleased that he's in that position. First I'd heard of it, so very, very pleased to hear that. I think there are issues, and I'll come to my sort of councillor colleagues as well in a minute for any comments they may wish to have. Obviously, elections are overshadowing all sorts of things at the moment. We were talking about devolution. I think the decision at Hull City Council just scraped through to move things forward with a chairman's vote to move forward the devolution proposals for the East Riding and Hull. So that's progressing as far as it can at this point in time, not knowing the outcome of the general election. I think there's a realism, certainly amongst us all, that there's highly likely to be change of government, and I know that there will be discussions going on behind the scenes with potential future ministers from any major political parties about how things might move forward in terms of local government, etc. So a lot up in the air, a lot of by-elections going on at the same time, particularly locally with us, with 2 by-elections, which could change the makeup of our local authorities. So always a risk of that. I think some of the key issues, particularly parochially with us, but wider, I think, is funding, particularly in public health funding, or lack of it in many cases, and lack of investment in that. So I think there will be quite a few discussions going forward about best use of those budgets, with the realism that there probably isn't a lot of extra money coming forward on the table. So it's how do we balance, particularly in public health and population health terms, the statutory requirements that those bodies have, coupled with the work we would like to do, particularly in terms of prevention, asset-based community development, and those sort of areas. And really a plea from me on behalf of local government colleagues, let's not lose the sight of the potential for some investment in prevention through the ICB, which I know we're all signed up to, but let's not lose sight of that and hope moving forward, irrespective of government, that we continue with the will to invest in that preventative work. Obviously, we all have financial pressures. I think there will be discussions we touched on earlier about continued healthcare, Section 117 agreements. I think there will be harder debates to be had moving forward between the NHS and local government in terms of what they see as the proper funding for those. Because my understanding is across the country, there are various mechanisms. Some it's just a percentage split in general terms. I think there will be harder debates to be had there, and hopefully the relationships around this table will make them positive and constructive rather than negative debates moving forwards. At a very parochial level, we've done quite a bit of work with our health and wellbeing boards in terms of what we call deep dives into particular topics. One was the cost of living crisis effect on health and wellbeing, separate one on climate change, and we've got one coming up on housing. Now, I know that's very local to our place, but the positive stuff that's come about those meetings is the connections that have been made between people that we all thought probably met up but didn't. So from academia, from NHS, from local government, there are now working groups forming themselves based on this work that we've been doing, which has been really, really positive and constructive. And hopefully it's something I might do a little note on, some of the benefits that we've found from that work moving forward. So I think I will stop there, because I say we're a bit clouded by elections and things moving forward, but a lot going on. As I say, a lot are problems we all know about around this table. But I'm happy to turn to my councillor colleagues if they've got anything they'd like to input as well. Shall I go around the table? Stan, I'll start with you, and then anything you'd like to add.
Well, I think you covered everything really, really well, actually. So perhaps just a footnote on a parochial level. In North East Lincolnshire, we have a slightly different arrangement because of reasons of history. But now we have a Section 75 agreement with the ICB. What we'll find going forward next year is the joint committee, which is ICB at place plus the local authority integrated care partnership members working together, will no longer be in shadow form. It will be in real form, and I look forward to that being a great example of how we can all work together. And be interested to see whether the ICB's spirit of delegation is carried through in practice.
Well, we stand to be tested, Stan. Yeah. And congratulations, Helen, too, because that is a really big achievement. And it does show us a way forward, so thank you.
And I also welcome my sort of new colleague from the East Riding, Brickshand, as well, and I know he's keen to progress those similar discussions to see where we sit at the East Riding with that, as I'm sure the other places are as well. So thank you, Stan. Michael, I'm only coming to you next because the screen is in the far right-hand corner of the room, so you're next if I go around the room.
Right,
anything
that's
you'd like
very
to
kind.
add?
Very kind. I'll be brief, Jonathan. Just to highlight one area that post-election will be interesting to see where policy takes us, particularly around care market reform and the proposed care cap, because there has been a fair amount of discussion in the last week or so with people confirming and maybe not confirming that the cap will be introduced. For those of you that are not aware, North Yorkshire Council acted as a trailblazer for the social care reforms. Losing track of time, I can't remember now, it was last year or the year before, I think it was last year, and they in some respects fizzled out. Part of the concerns that we raised were around being realistic about the funding of and the impacts of introducing a care cap without the funding to match it. And I do think the main political parties haven't quite got either their head around that properly or got their story straight. So I do think that's one just to watch out for. From my perspective, quite bluntly, in terms of the amount of reform that's needed, okay, the care cap might be on the list, but it shouldn't be top of the list. There's greater issues to face the care market before we do that. So just one to watch post-election is what I'd say. Thank you.
Thanks very much, Michael. Linda, anything from yourself?
I think they said it all, haven't they? Care. Everybody's been talking about sorting out costing care, and nobody's actually done anything. I'm waiting to see whether that happens. I'm pleased to see we're recruiting, but I would like to make sure we retain them. Once we've recruited, I think that's one of the biggest problems is we can recruit, but we can't retain.
Yeah.
I think that's definitely something that needs looking at.
Yeah. Thank you, Linda.
Yeah.
All done?
Yes.
Any questions for Jonathan or his colleagues? No, thank you. We're going to move on to item 9. This item is with Charlie Jeffrey. Charlie, we had a Futures Group meeting this morning. I wonder if you'd be kind enough just to update the ICP on that and those observing us today.
Very happy to, Sue, and it was a distinctive, special Futures Group meeting because it was combined with the meeting of place directors, which I felt was a very fruitful combination. What did we talk about? Look, first let me remind you of the purposes of the Futures Group, which was to explore issues which had a medium-term timescale, so not in the here and now of the NHS or of social care, but thinking about some of the things that we could begin to do now which would have effect over a longer timescale. And it was to be done with a wider conception of partnership than that which is reflected around this table. So extending into universities and colleges and into the private sector, companies large and small, to offer additional perspectives and a check on the thinking within. We have made really significant progress on our first programme of work, which is broadly in the Start Well space around children and young people. It is something I've talked about before under the heading of Connected Humber and North Yorkshire. Broadly speaking, an attempt to adopt lessons from the Connected Bradford programme and explore how that might be delivered at the scale of an integrated care system. This is about connecting data sets across health, education and other domains. It's about mobilising academic research so that we can maximise the insights from those data sets and to deploy them with professionals on the ground in and with and for communities. So that's the ambition. We are now in the process of defining how to deliver this project. We heard about developments in governance this morning in two dimensions. Firstly, how do we manage access to and consent around those data sets in the appropriate ways? And then secondly, how do we manage a project which is explicitly focused on the medium term and not on the short term issues that we tend to talk about, and which has that commitment to bringing in wider perspectives. Work on that underway. Initial pilot projects being developed. York and North East links are the starting point for that. Exploring how we might connect health and education data around autism diagnosis, and in particular understanding how we might work with schools through our various organisational forms for schools. And then finally, a full business case to understand how we might develop this project beyond those pilots and how we might understand the return on investment is also underway. So that's programme 1. At our last Futures Group, we kicked off what is swiftly becoming programme 2, which is in the ageing well theme of the partnership. We tasked one of our colleagues, Una MacLeod, who used to be the Dean of the Hull York Medical School, now an academic GP working at the University of Hull, to set some thinking going. So we've had 3 workshops on how this programme of work might unfold. And out of that, we discussed this morning a number of themes. At the heart of it, I think, was inequality. That's partly about how disadvantage and lifespan correlate, but it's also, and very significantly, how disadvantage and the span of years of ill health correlate. So if you are disadvantaged, you die younger and you have a longer period of ill health. So that's one of the conundrums that we're looking at. Lots of thoughts about what preventative action means in that context, which is something we need to unpack further. Lots of thoughts about how employment is one of the key parameters for healthy ageing and well-being, and understanding the roles and attitudes of employers will be a key part of future work. Role of technology in enabling people to maintain independence in their life and in their living will be another theme. A significant concern to not get tempted to present age as a deficit that needs to be compensated, but as a rich part of our lifespan, which we can help to make even richer. And then finally, and perhaps a way of clustering all of these issues, a focus on our coastal areas, which have a combination of general patterns and challenges around ageing, but also of imported challenges because of the tendency of people, often from disadvantaged backgrounds, to migrate to coastal areas to retire. With a caveat there, we recognise that not all of our ICS region is on the coast. There's quite a bit of it which is not coast. So we were beginning to think about, well, could coastal be a first wave and rural be a second wave, because many of the equivalent issues apply in both of those contexts. We didn't come to a clear answer on what we would focus on, but that helped us, I think, to begin to plan a series of workshops which will take place over the summer, where we will define more clearly the what of this project, but also the how of how we will go about it. And I think that's where having the place directors in the room was really, really significant, because I think it's all going to be about joining up in places across different parts of the public sector and reaching into the private sector in those places. A final thing we talked about, which was quite fascinating and had emerged in the context of the workshops on ageing well, was the liberated method. And I'm not sure, for those who've joined us since lunchtime, whether they understand that terminology. No. Okay. It's in part an academic terminology, but being deployed in concrete settings, and we had quite some insights, both from work in Gateshead, but also some exemplification in North East Links as well. It is, if I can quote from a report on this, creating the conditions for people to access their own capability to thrive. In other words, a person-centred rather than a service-centred approach, one which pulls in the resources needed to support the capability to thrive, rather than referring on from one service to another, which can get terribly complicated. And I reflected during the meeting on a brilliant example from Gateshead, a case study involving somebody named for this case study as Brian, an alcohol-dependent man who had, over a period of a couple of years, consumed about £2 million worth of public services. Very, very frequent attendances at A&E, frequent engagements with the criminal justice system, frequently needing emergency overnight accommodation, and I'm sure you will be aware of cases like that. Through the application of this method, a person-centred rather than service-centred approach, Brian is not yet a fully functioning member of society, but the costs of supporting Brian are about £70,000 a year now, largely through accommodation, rather than something which quickly stretches into the millions. Now that's a really compelling, probably a quite extreme example. Yeah. And it led me to think about a concept in a report I read on this called resource stalemate. And let me quote a paragraph here. A resource stalemate exists which makes it very difficult for any agency to focus on prevention issues or anything upstream of the eligibility criteria that defines their minimum service offer. For example, adult social care investing heavily in prevention would reduce demand into the health and possibly the criminal justice system, like Brian. But it's very unlikely that any savings made would find themselves manifesting as investments in adult social care. The budgets are buttoned down tight, and therefore it's in no service or organisation's interest to blink first and go hard at prevention, because the benefits might be felt somewhere else and not in your own budget. I think we heard in the meeting this morning real commitment around the table not to think in that way, and real examples of not thinking in that way and working across service and budget boundaries around a more person-centred approach. And I think the insight was that there is such a tremendous opportunity for a partnership which extends across health and social care, but which has the potential also to extend through place into other policy domains, really to pioneer and make real that kind of collaborative, person-centred approach, which has the potential to save so much money to the public sector. And that, of course, is really, really relevant to our two programmes of work on Starting Well and on Ageing Well. So I think that combination of issues this morning was really, really rich, and I think sets us up with renewed confidence and enthusiasm to take these projects forward. Thanks, sir.
Thank you, Charlie. Any questions for Charlie in relation to the Futures Group? Yes, Jonathan.
It's just a comment, really, and a reflection, having heard what you've just said, that these issues we've known about a long time. The barriers, I think, are because we're so entrenched in local government and social care or the NHS. To have yourself telling the story effectively from the outside in that way is a really strong message.
Yes, it's very, very, it's
and,
very
I think it helps us all maybe move things forward from that point of view. It was just how it came across to me, that was all. It's like that independent view of what we've all thought about for years but never actually buckled down and got on with. So thank you.
I think the ICP meets again in 3 months' time, and so it's likely by then that we'll know what the theme is going to be of that second big project. So let's wait to hear from that. So many thanks, Charlie. On to item 10. Item 10 goes to Peter Thorpe, and this is the Shared Framework for Excellence, Sustainability and Prevention at Place. So Peter, should I hand over to you?
Thank you, Chair. And thank you, Charlie, because you've set this up extremely well. There was another quote from the Futures Group this morning from the presenter we had, which was to say, collaboration is the only way to sustainable public services. And I think, that's an echo of what you just said there, Charlie, and we all know that, and we know what the barriers are that get in the way. We also know that if we are going to collaborate, then the first point of that is going to be built on the relationships that we hold. And so, as we were developing the strategy that we're going to go on to talk about in the next item, one of the commitments that we made early on was if we have an operating model which is based on a singular ICB, being as small as the ICB needs to be, 6 places and 5 provider collaboratives, we have to enable all parts of that model to be as effective as they can be and as empowered as they can be. So we started to talk about what would a new deal or what would a new relationship for place look like. But we weren't quite ready to go on that work because we know intuitively that there is a premium in this way of working. We've just heard about it. So that's the premium of place. But we've got to get some conditions right. So to get the conditions right, we asked a piece of work to happen throughout the system with some leaders across the system to say, well, what is that place relationship and have we got a singular view of it? So people who are in this room, Karen, Karina, the place directors, were all a part of this. And particularly just to give some credit to Julia Weldon, the Director of Public Health and Deputy Chief Exec at Hull, and Richard Webb at North Yorkshire, who were also heavily instrumental in this work. So that was the purpose. The purpose was to set the relationship. The process was we came together to work through using the system leadership framework that we've agreed, which is we are here as a system to lead for excellence, lead for prevention, lead for sustainability. And the product is the place framework which you've got in the pack. And I don't intend on this item to go through the place framework. It is almost, it's the consequence of writing it down, and that's the discipline. However, the real prize was in how this has then created the conditions for the relationship. And the latter part of the forward report gives a sense of what's happening in each of the places as a consequence of this. But significantly, and this goes to Councillor Shreve's slightly pointy comment about are we going to delegate with meeting, is yes, I think we're now on that journey, not just in North East Lincolnshire, but meaningfully across. The conversation is now live in each of the places. Now, not each place might end up with a joint committee and enhanced Section 75, but mainly the majority intention is to get to that place for the beginning of next financial year, which then sets us in a position to say we are genuinely entering into the place agreements in a way which is delegation of resource and decision making. Now, there are some bits which are still moving in that, so I just want to kind of caveat some of this. Clearly, the ICB is still developing. We are also delegating into collaboratives, and there was a decision at the ICB board the week before last where a significant delegation to the mental health collaborative was made, and we're doing the work in place. So there's the operating model matures, but we have to almost mind the gaps as we work our way through that. But I think in terms, just to kind of summarise, Chair, I think this is a really positive place positive position to have moved forward these places.
Great, thank you very much indeed, Peter. I don't know if any of the place directors want to add anything, or if there are any questions from those in the room around this shared framework for excellence. Stan?
Just partly response to my comments were slightly pointed, they were, but in a spirit of wanting it to succeed. And I think what this report does is help to establish the framework and the governance framework in which it can succeed. Yeah, and hopefully that can be communicated to all levels within all organisations, which is where the problems lie, if there are problems.
Thank you. Yes,
Can I just respond to that, Chair? Thanks, and you've also reminded me of there were some other prizes in this as well, not least that a commitment to put some structure to how we are learning from each other across the places. So we're talking about those peer review functions which allow us to say, that's happening over there, or we want to test that over here, and then being able to kind of come together around those. And I think that's, again, is part of that.
Lovely. Okay. Sarah?
Thank you, Chair. Thank you, Pete. I thought, just giving a place view, really. I think the place framework has been, I think, a real lesson in places coming together and seeing the power and influence that places can have by working together. And it's really galvanised action, I think, within, speaking on behalf of my own place board and taking this through, we have a really clear view about the destination as a result of a strategic place framework. And we have a real clear view on how to get there.
Right.
So I think it's helpful and important just to impress that point that not all ICPs or ICBs indeed have such a clarity on their destination. So I think it's actually a real pivotal importance on behalf of the leaders within places as an example of where we come together. I think it's a platform on which to build. So we talked this morning in our Futures Group session, which Charlie's alluded to, around the important role of places in prevention and really starting to move beyond having a culture and mindset that's set about tackling prevention and actually putting the mechanisms in place. Because we've tried to do that for decades, haven't we, in terms of finding those mechanisms to be able to shift to tackle the wider determinants of health together. So back to that point about sustainability, the potential for places to work together around those mechanisms. I think this strategic place framework gives us the ability to do that.
That's lovely. Thank you, Sarah. Anything from anyone else? Okay, well, you'll be pleased to know that was my part of the agenda. So I had 4 partnership updates. The one from Pete around the shared framework, the one from Charlie around the Futures Group, one from me around where the Integrated Care Board is preoccupied, and one from Jonathan around the Local Government Partnership Report. But that ends that part of our agenda. So we're going to move on now to item number 11. This is the Integrated Strategy for Wellbeing, Health and Care. And this would seem to be you again, Pete.
Excellent. Yeah, thank you, Chair. So I'm hoping what's going to happen is whilst I...
Sorry, I was taking you at that point. I'm going to let Sue carry on.
I'll be quiet now.
Hopefully a clicker will arrive very shortly for the presentation.
Do you want it? Or do you want me to do it?
No, I'll... Thanks, Vicky. Very thought I could delegate clicking just seems just a step too far. I am actually going to run through this as a presentation because there are only 18 slides, and just before you sort of think of 18 slides, we're going to flick through this quite quickly. This is about if you recall back to the last ICP meeting, we'd gone through a process of a really thorough process to write our integrated care partnership plan, our strategy, with huge levels of engagement. But we also recognised that inevitably in the first writing you kind of show all your workings out, and we wanted to go through a process of what we called lift and simplify, almost a can we see the wood for the trees. We've been on a journey of socialising the work that we did, which we saw last meeting. Health and Wellbeing Board chairs have, I think, Karina, you've had 2 meetings with the chairs, haven't you? The Systems Leadership Forum, where chief execs come together and place directors have had a good look at this. Chairs of provider organisations have been engaged. The ICP board has had a very good look at this. Clinical and professional leads, and then partners such as Sports England. So that the journey of socialisation continued after last meeting, and this is the final formatted version. So I will go at a fair speed, but I just want to make a few points on this. So this is first of all, the cover. I know this may sound a bit daft. These are pictures of real people who live in Humber and North Yorkshire in our places, and without a face mask in sight. So I just wanted to kind of make that point that we've deliberately made the imagery about the people who we are here to serve. And in the introduction from Jonathan and Sue, who, as you see, haven't aged a day since the last strategy, what we're doing there is positioning some of the changes. So the significant change of the commitment of this partnership to a generational change in wellbeing, health and care for today's children. Wherever that proposition has gone, that has been extremely well supported by all partners, clinical, local authority, wherever you look. We discussed at this meeting last time whether we thought that the commitment to what we've called our person-centred and strength-based approach, it doesn't quite work on this slide. It's a low resolution, so it is better in the final one. Are we still committed? I think everything we've heard today says that strength-based and person-centred is the way forward. And then we reaffirm our commitment to keeping the voices of people we are here to serve helping us to drive that excellence, prevention and sustainability. So there's a slightly reworded introduction. We recognise that our communities are incredibly diverse. I won't drop too much on that. And for some reason, I do apologise, for some reason this is not coming through on the screen particularly clearly. So you might want to look at the one that's in the pack. It does look a lot nicer than this, but we've kept, whilst it looks like a lot of boxes on a page, we have kept this format because through the socialisation, that frame kind of created some value in its own right in that everybody understood it. But what you can see is it takes us through those headline aims of narrowing the gap in healthy life expectancy by 2030 and increasing healthy life expectancy by 5 years by 2035. So there are aims that we have. We positioned our start well, live well, age well and die well, and then it takes you down through the ambitions, the person-centred approach, and crucially, and this is where we are different, being clear about what the drivers for this strategy are and giving some headlines to that. So very quickly, that's very familiar. Partnership ambitions, you can't read there because I have no idea what's happened here. But the children has been sort of elevated within there, and then this is important. We've positioned our ambition for children as our golden ambition, and this has had some quite significant separate work done with looking at our public health, looking at our population health data, our public health data, working with our directors of children's services, taking this out for its own sort of journey of socialisation to say what are the hooks we're hanging our ambition for children on. So you can see it's prevention and early intervention, healthy pregnancies, healthy start, learning well, which crucially links into education, emotional resilience and mental health, care experience children and young people, and health and care futures, which is the connection into improving access to careers. Underneath those, they pull out some priority actions that we have, and those have been refined, particularly after feedback from the chairs of the health and wellbeing boards. We've reaffirmed the person-centred approach. The big four, we've lifted up. This has again survived the journey of socialisation. So we know that if we can reduce harm from cancer, if we can cut cardiovascular disease, if we improve living with frailty, and we enable mental health and resilience, if we can make a real dent in those four, then we would be much closer to achieving our aims. So everything follows on the back of efforts there. And we've talked about this shining a light on these big four. There will be a partnership approach to that methodology, which really allows us to get into that outcomes-based approach to, okay, well, what do we need? What curves do we need to turn to reduce harm for cancer? Where are we going to get upstream of this so that we are truly impacting in the way that we are trying to aim for? So it starts to kind of create a methodology there. And then what follows, we unpack, not in any great detail, but some system commitments to, so what do we mean by leading for excellence? Where are we going to make our investments, and what is our intent? So you can start to see how we are unpacking that, so in terms of innovation and research, cutting edge approaches to digital data, empowering providers to work collaboratively, and so on. I mean, I won't read them all out, but you can get a sense of there's a bit more engine under the bonnet in the way that we're presenting this version. And then again, voice at the heart as a commitment. And then the appendices, just to finish off, I mean, the partnership we know the complexities and the opportunities that our partnership brings us. There's some governance. And then this is, again, slightly different in that we recognise that this strategy only exists because it is built on the health and well-being plans of our 6 places. But in turn, we will need some system plans to make good on this. So what this kind of wheel does is it centres the outcomes framework we're going to hear about later on the agenda as that's central to where we're aiming, because that's about what is the difference we're going to make for the people the 1.7 million people who live in Humber and North Yorkshire. But it then starts to signpost where the plans are which will make good on this. So there's clearly an IRIS plan for research, there's a breakthrough plan around workforce and so on. So I think that's it, Chair. So with apologies for the format not being quite right on the screen, happy to take any questions.
Thanks very much. Any questions for Peter? Because I know this has evolved over time, and we've had sight of it as it's progressed. And my only question is, when we talk about outcomes framework, so what stops it sitting on a shelf for a year being reviewed, and what are the outcomes, the figures, the things we can look at, say, yeah, it's actually working, it's pulling together as it should be. Yeah. Or maybe that comes into the outcomes framework that we're going to talk about.
Well, I would say that's absolutely the right challenge, and in many ways, creating the delivery plan framework underneath, and the governance for that means it has to be driven. The operating model is strongly alluded to this within this, so it's again taking the operating model to its next place in the way that we've heard about this morning. Children's plan, we haven't had a children's plan. That's now forming. So I think what we see is almost by having the less is more approach, we can be certain that we are going to drive those areas that we've committed to, rather than having a plan which tries to document everything that might be happening. So there's still things which are important, but they're not the priorities that we've created here.
I always feel it's nice. In the number of documents over the years, you have your photograph at the front of with a summary, There's very few of them 10 years later that you still have on the shelf. I think I'm really proud of this. And I would like this to be one of those. Maybe Sue and I look back at it years to come and say, this really led to some change. Yeah. Any other comments for Peter?
Jonathan, you may not see my hand up.
No, I can see half your head at the moment, Stephen. And
that's
probably
no good, is it?
Your
Yeah,
hand
well,
is probably very small in the upper corner of the screen. Yeah. Shout out, please do.
Is that better?
Yeah, that's fine. That's fine.
I know I'm not in the room, and so I may not have read this entirely correctly. So I preface what I'm going to say by saying that. But I'm sort of from a different lens, coming from where Stan was sort of coming from, looking at it through the place lens earlier. So everything we've done today that we've reported on is absolutely on the button in terms of where we need to go. But I just wanted to sort of ground some of this conversation in some of the harsh reality that I don't think changes with the change of government. I think that there'll be a change of emphasis. I think probably importantly, this direction of travel will be that we're rightly on, will be sustained. So the first thing I want to say is, here are some examples of what we're doing now that will prevent us from doing many of the things we're aspiring to in these strategies, this strategy. So I know some of this has been heard before, but I think it's worth repeating. It channels the mainline agenda we've been talking about around the nature of the population in our area, effectively a significantly growing and aging, growing in the context of aging population. So if we continue with the infrastructure model of service delivery that we've currently got, and I think that isn't just about the NHS, even though this is clearly flavoured with NHS strategies. The fact is we'd have to put 2 additional acute wards in place every 2 months, or build a Harrogate hospital every 2 or 3 years. So that's one reflection. The second one is we spend, I think, and James in the room, at the moment, on the whole pathway of emergency care linked to suitable alternatives for those people that shouldn't be in the acute setting, £180 million per year. It's a massive amount of money. We're also spending in the order, and this is NHS, of around £100 million per year on agency and bank costs. Some of that supporting services that actually are not sustainable and not really designed to meet the agenda that we're talking about. So I just wanted to land those. I could give other examples, but I'm sure there are very similar examples we could quote in the other public services. I mean, I know there are significant pressures, Charlie, in the universities, and we were hearing the other day, Sue, in a meeting we were in, about some of those as they affect the University of Hull. I'm sure it's true in York as well. So the reason I say all of that is we're absolutely on the right road. And Peter, you did mention, but I think we have to land here, Sue, the other two big commitments we made when we had our ICB time out earlier this year. So number one was the generational change aimed at children. Number two was, despite all of that, we would focus on spending somewhere between 5 and 10% of our resources in health. I mean, we clearly couldn't make commitments necessarily around our wider partnerships on what we were describing as prevention, but really this whole shift that underpins the conversation we've had today, and doing that in an environment where there isn't a lot of extra money to make that shift. And the third bit of that commitment, or the third element of that commitment, was to create a surplus over the medium term, over the next 3 years, in our financial resources. So I don't want to spend a lot of time going into depth on that, but I think it's important just to land in the context of all these things that we're pressing forward with. There are some, and Jonathan, you mentioned this in your opening remarks, there are some really tough decisions that we have to take together, and I would accept. I think that point this morning, collaboration is the only route actually to make progress on all of these programmes of work and this particular strategy. So I'll leave it there. But and I wasn't suggesting, Jonathan, we had a long conversation about that, but it does mean some very, very difficult decisions in the next few months about how we allocate our resources and how we challenge the way that we currently work. Thank you.
Thank you. Thanks, Stephen. I think what would be useful in general terms over the next few months is a better understanding across the system of the pressures faced. I had a very brief chat with Charlie about the pressures that you alluded to in the universities, and the quite serious decisions they will have to take. It's the same in local government. We are, well, to a certain extent, putting sticking plasters on for a couple of years and using a bit of reserves, and we'll struggle through. But I think the more we understand about each other's issues around that, the better, because it does help focus the mind a bit. Because I have no concept of what you have to do as NHS bodies to make the sort of savings you need to do. I can work it out in sort of local government terms because I can get my head round a local authority and where the pressures are. I cannot get my head around this total NHS system. And does it just need more money throwing at it? Are there huge savings to be made? I don't know is the answer. And I think the more we understand amongst ourselves those pressures, the easier it is, to be sympathetic towards each other when those hard decisions have to be taken. Sorry, that was a real councillor rant, was that? Yes. Any other comment? No, we take on board, Stephen, I think, everything you said and accept that. Any other comments anybody would like to make at this stage? Because if not, then we'll move on to the next item, the outcomes framework, which links into to a certain extent. So, Jake, can I hand over to you? Thanks very much.
So this is a short update on work that we, I think, brought to the partnership board previously around the development of our measurement approach to understanding how we're progressing against the ambitions, outcomes set out in the strategy. So we commenced the work in October. We've been doing some revisions, development of it in line with the emergence of what Pete talked about in terms of our four shine a light priorities and use this the golden ambition around children and young people. and looking at the context for things like the place framework. But the principle still remains, which is how will we know if we've succeeded? We still have the statements which feature in the Lift and Simplify strategy as well, which we'll have gathered as part of the strategy work, which set out those things that we've captured as quotes about how we'll know how we're progressing against the 4 life course domains on start well, live well, age well, and die well. And we've been looking at the sort of metrics that you'd use against those. And similarly, we've got obviously a couple of very high level key outcomes around healthy life expectancy, around the gap and around an overall improvement in healthy life expectancy. And then what would we use as a quite a sort of high level set of measures around each of those 4 Shine a Light priorities, and what would we use around children's, linked to the children's plan that was mentioned earlier on. I think some of the challenges with this, we're trying to keep it as simple as possible. There are hundreds of measures that we could use, and we want to have something that gives us enough of an understanding against the things that we've set out. And also recognise that a lot of these won't move necessarily quickly. So they're high-level outcomes which, if you're going to turn the dial on healthy life expectancy, which we've talked about in previous sessions, it is a hard thing to change. And what we need to do, and I think this is the key point from the work, is to understand the connections and how the things that we're going to monitor on a longer-term basis will be impacted by the actions on a day-to-day basis, and what sits within our place plans, what sits across the work of the collaboratives, what's going on through our committees, and how we draw those connections. So we'll populate the high-level outcomes, but I think the bit that we're really trying to flesh out over the coming months is, whether we call it theory of change models or logic models, that say, actually, what are the evidence-based interventions that we know are going to have an impact on outcomes for CVD, for example, and where do they sit across the work of the partnership? So who is accountable, who is going to be charged with trying to deliver these things that we know are going to make a contribution towards shifting the dial on these big, long-standing challenges. So that's where we are at the moment. There's a kind of element of retrofitting, I suppose, because we've got joint forward plan, we've got place plans, we've got a lot of this in place, and we're trying to say, well, what are you planning to do this year? Can we look at that and map it against all of these, the high-level outcomes that we've set? There is some alignment, and we were testing this with place reps the other day, but I would hope over time that we're able to exert some influence that says, actually, what else are we going to do if we're really going to try and tackle life expectancy, if we're going to try and tackle children's outcomes? What else do we need to do across the system, and which bits of the system where should this feature in different plans? But that's where we are at the moment. The other thing I'd say is that we're using our collaboration on analytical functions to get into some of the more detailed technical work around this, which includes how we measure health inequalities systematically. So whenever we look at outcomes, we can look at what's happening differentially across our protected characteristics, social inclusion groups, deprived communities, for any of the metrics that we're using. And then similarly, how do we make sure we're able to look at quite granular level? And people have talked about it's not enough to look at district level, even place level. So we need to understand variation and progress at whether it's neighbourhood teams, small areas, your different partnership geographies that you use across the wider system. And then the other thing just to mention again was the use of the incorporation of data on voice of lived experience, and we've made important connections with work going on through comms around our insight bank and how we use qualitative research and evidence alongside the hard data to really flesh out and give us that more nuanced understanding of progress and challenges for the work that we're doing. I'll leave it there for now, but happy to pick up any questions. I'm looking to present the work at the next meeting, if that works for the board.
Fine. Can I ask, Jake, from my mind, in terms of the information you'll be providing, how much do you see your role as saying that this is the key information you need, and how much is your role also saying flagging up where you see some anomalies, problems and issues we should be looking at? You know, how do we use all that information collectively, and who starts triggering things to move forward?
So yeah, I mean, thank you. That plays very much into these concepts of things like decision support units, strategic intelligence functions, where like you say, in addition to updating on progress, you know, looking at variation, looking at our outcomes, we're actually doing think pieces, looking ahead, horizon scanning. Where does it look like we're actually off track? What are the things coming up that are likely to present problems to the system? I'm really keen that we establish that function properly, and then we build it into the way that we engage with groups like this going forward. And it's very much at the heart of the decision support unit proposal that we've got, which fits with, not throwing too many terms, the connected Humber and North Yorkshire vision that Charlie updated early on.
Thank you. Any questions or comments, observations? No? In which case, Jake, thank you very much. And we look forward to seeing this evolve next time we meet. Good. Right, I now move on to ageing well, which will, I know we've talked a little bit about ageing well today from this morning's session, but I hope this is sort of alongside that, this next section. So I don't know who's going to lead on this. Jack, I've got you head of the list of 4 potential contributors here. Do you want to kick off?
Sure, I can do that. Happy to. Yeah,
thank you.
Chair. So this is a presentation developed by me and Jake here, and it's sort of a follow-on from the Chris Woody presentation to our system that happened about a month or 2 ago. So it's our localized version of that. And colleagues around the table will, to some extent, have seen some of this, and Stephen's preempted part of it. But I think important to describe what in the agenda says is a population time bomb, but I think it's really a tsunami, and it's a tsunami that's already here. I'm going to get into why that's the case and some of the challenges and nuances to that picture. Before I finish, you will understand that this is real data that shows how our population is growing over the next 20 years or so, but it's not the real picture. And it shows a pretty marginal gain in growth, about 4% population growth overall for the next 20 years from, we've indexed back to 2018. Always worth pointing out when I talk what our overall ambition is, and you've seen that reflected in the strategy again, which is great, and then our overall ICS duties, 2 of which relate to outcomes in population health and then tackling inequalities. For background, you will all appreciate that life expectancy and mortality in this case differs by deprivation. So that's something we understand well. Most deprived decile there is on the top, and the least deprived is on the bottom. Obviously, deprivation, think of that as poverty. When we think about that gap between top and bottom of most deprived and least deprived, those are deprivation deciles, and those are reflected here as well. On the far right of that, there's a much larger gap over to our inclusion health groups. So really important when we're talking about our population that we think about inclusion health groups, which include Roma Gypsy travelers, asylum seekers, people in contact with the criminal justice system, people who misuse substances, and we cannot forget that they are distinctly disadvantaged. Here is roughly what our geography looks like in terms of the populations that are in the 40% most deprived nationally, fairly scattered, a bit of a coastal element to them. And I've presented to this group before that it's actually not exactly accurate to look at it in this way. It's more accurate to say, let's look at all of those spaces of geography equally accounting for population density. And when you do that, it clearly shows there is lots of urban deprivation to be accounted for in our geography, including in York and in Harrogate, up in Whitby, certainly in Holborn, Scunthorpe, Billington, and you can see there's a bit of a coastal element to that as well. So now let's localize some of those pictures. Here is our life expectancy gap at birth across our places, and there's obviously quite a big gap between Hull, which is in the bottom 10 local authorities in the country for life expectancy, and East Riding, I believe, or sorry, North Yorkshire there has the longest life expectancy. It's not quite right to look at life expectancy statically over just 1 year. We need to look at it over time. And this is one way to do that. So this compares both life expectancy and healthy life expectancy changes over about the last 10 years. You want to be in the top right-hand quadrant, which means over the last 10 years, life expectancy and healthy life expectancy have both improved. The left-hand side is males, the right-hand side is females. So North Yorkshire, York on the male side, and then females East Riding both do that. Significantly, and this is my first challenge to this partnership, we have places that are not in that top right-hand quadrant. And at the extreme of that, you can see Hull there, where the life expectancy has gone down by 1.5 years, and the healthy life expectancy has gone down by about 4 years in the bottom left there. You can see northeast Lincolnshire on the female side, on the right-hand side, where life expectancy has decreased by about 0.5 year, and healthy life expectancy has decreased by about 6 years. So people have lost 6 years of healthy life expectancy. Women have, females have, in northeast Lincolnshire. Over the course of life expectancy changes globally in the last 40 years, we know that the life expectancy has increased by about 19 years. The trend is that comes at a cost of about half of those years being in full health. So we live longer globally, that's good, but half of those years are in poor health. So keep that in mind as context. Okay, moving on to our population growth and why this isn't the real picture, and just a tiny bit more context for you. If we look at the hospital admission rates by age, and this is a piece published in the BMJ, and you distinguish between those who are under 15 years and in different age categories up to 75 years and above, the admission rates for our older populations are drastically going up. These are back to 1999-2000 through to about today, about pre-pandemic. So hospital admission rates are going up. If you disaggregate our population growth by those same age categories, you see that our over 75 population is increasing drastically. And again, I've indexed back to 2018, so these figures are set to 0% growth in 2018. And by about the point we're in now, we've already experienced 20% growth in over 75s from 2018. And by 2040, that is over 60% growth from 2018. Now, to put those in real terms, here are the numbers. So already, where we're set today in over 75s, we've grown by 40,000 people from 2018 over the age of 75. And this is where, when Stephen talks about the extra capacity that we need, we can do some really simple maths that said if we just look at the state of the system and how it performs and length of stay and disease prevalence, we can say pretty confidently that if we do nothing, we need an extra ward built in our hospitals every 2 months to keep up with this level of population growth. That's a do-nothing scenario. Now, this is fairly uniquely a Humber and North Yorkshire issue. It's around the country a coastal issue and a rural issue, and so we obviously occupy both of those spaces. It is not a London issue, it's not a West Yorkshire issue. So something to be really conscious of there. It is our challenge to solve. With aging populations comes a change in disease burden, and this, from global evidence, we know that cardiometabolic diseases, cancers, mental health issues, substance misuse, neurological disorders all go up. So we have to be very conscious of that as we design the healthcare system that's fit for the population changes we're experiencing. If we continue to model these, and I've just chosen a few examples here to put some numbers into the picture, we know that by 2030, not far away at all, we're going to have an extra 2,000 people living with dementia. We're going to have an extra 6,000 cancer cases. We need an extra 400,000 GP appointments per year, and this is broken down by place. So it does vary, obviously, based on how the population is aging across our places. And we're going to need a lot more care home beds. Purely based on the maths, if we do nothing, that's what population growth does for our area. Here's a map of where there is greater than 20% of the population over the age of 70. And these are the places that are going to experience the most population growth. So they're the ones going up and to the right in terms of over 75 populations, an extra 60,000 people coming into our system over 75 in the next 6 years. And this is our second challenge. So the first challenge was widening inequalities. The second challenge is population growth. Take a look at where those areas are, and take a look at where the areas are that have deprivation in our system and have increasing health inequalities. I'll just flick back and forth there. This is unique to our area. And if you think about where the demand for services are, the expressed demand for services are, they're going to be here. More dementia, more cancer cases, need for social care, need for GP appointments. When you think about where the unexpressed need is for care, it's going to be here. So we have to very consciously respond to both the needs and demands in our system. The natural state, I think, of a system is to respond to the capacity demands that are put on it. If we do that, we leave behind these areas here, which we know look fairly concise on this map, but when blown out to express population density are a big chunk of our population. I think this is really well expressed by this graphic showing alcohol deaths in England by deprivation. So moving right to left is affluence. So left to right is poverty, so more deprived on the right-hand side. And looking at it age, top to bottom, so older people on top. If you look at the annual deaths, there is this protection that happens by deprived groups. Affluent groups don't see alcohol deaths. They're all stopped on the far right-hand side of this graph. This is our unexpressed demand for care. It's unexpressed need, apologies. The need for preventing alcohol deaths and the disease burden from alcohol exist over on the right-hand side there. We have to be really careful that we're representing that population. The demand for services is going to exist on the far left-hand side of this graph that don't necessarily have as much of a need or have an equal need to those on the right-hand side of the graph. So a few quick thoughts on how we respond to these challenges. I think there are 4 ways. So we can either increase capacity, and we'll absolutely have to do that to some degree. We can improve how productive we are or efficient we are, and there's big P and small p to that, so transformation that you capture within that. We can make sure the care sectors are balanced, so between health and care, between secondary and primary care, and having people seen at the right place across the system, and making sure that capacity is correctly positioned, and we can focus on prevention. I think the challenge in addressing those 2 challenges is let's make sure we're always drawing the logic model between what we're doing and it reaching these 4 objectives here. If we think that purely increasing capacity is going to do the trick to reach the size of the challenge we have, the logic model will probably quickly say we're not building that many wards in that short of an amount of time. If we think efficiency and productivity is going to solve the challenge and say ambitiously we're going to get 50% more productive, pretty simple math says we're not going to meet the size of the challenge if we get incredibly 50% more productive at what we do. So we have to focus on prevention. We have to focus on balancing the care sectors correctly. Chris Whitty is very good at explaining that healthy aging isn't inevitable either. So the left-hand graph there describes the life expectancy gap in our area in more deprived groups and split by male and female. We know that a lot of it is to do with circulatory diseases, and during this time period it was COVID, and cancers. much of which, on the right-hand side, is preventable. So 42% of the entire disease burden is preventable and due to adjustable risk factors. So we need to be focusing clearly on that 20% there that says tobacco. On a lot of that has to do with alcohol and other risk factors. And finally, we absolutely have to recognize the wider determinants of health. We cannot do this as an ICB. This is clearly an ICP challenge. On the right-hand side there, looking at what contributes to overall health. We know that health care is only 25% of that picture. Genetics, which for the most part can't be avoided, are a small fraction. And the rest is socioeconomic and environmental, which both sit within the partnership domain. And the left-hand side, healthcare services is highlighted there in the bottom right, but clearly lots of other factors that go into that socioeconomic and environmental picture. I think that's me.
Thanks very much. I'm just wondering, with the rest of the team on the screen, if anybody has anything they'd like to add that's been involved in the work to date. Please pop your hand up if anybody wants to add anything.
So I think some of the team on the screen are going to talk to us about some of what they've been doing, and so we probably want to do a round of introduction. Well, not all of us, but they may just want to introduce themselves as to. So Dr. Anna Folwell's here, who's from the Jean Bishop Centre in Hull, and the anticipatory care model that they've been introducing there, and a couple of colleagues from our local authorities who are talking about their age-friendly cities and community work that they are doing, and then Yvonne is here for the community collaborative and the work that we're doing around the Centre of Excellence for Frailty.
Okay. Should we just kick off then? And Anna, shall I start with you and you can tell us what's happening? Thank you.
Thanks very much, and thanks for having us. I've got a few slides to share, if that's all right. So hopefully you'll be able to see them. Is that sharing?
Yeah.
Perfect. Basically, I wanted to share how I think the work that we've been doing from a proactive care perspective from the Jean Bishop Care Centre in Hull and then East Riding has helped to inform some of the Centre of Excellence work for frailty, and hopefully has a part to play in responding to some of those challenges that Jack has articulated. So I was just going to go quickly through some of the core principles that we're trying to focus on, the stock take across the ICB, and then what we're going to be doing. So there's various different documents that have been published by the British Geriatric Society, NHS Elect from a frailty perspective, and then the GIRF reports on geriatric medicine. Between them, there's about 40 different kind of principles for good aging well and frailty care. So what we've done is we've tried to distill them down to 10 principles, and a lot of them speak to how we have a more preventative approach and support people living well with frailty. I'll talk a bit about identification in a minute, but a lot around understanding our population, how we support independence, and then delivering that kind of proactive care closer to home that we know people want, and is much more evidence-based now. And then some of the principles are more around the enablers that we can use to help develop these kind of proactive models. So around digital, how we can look at a workforce that can deliver, that's both improving specialist care and then generalist care, and using kind of quality improvement approach to that, as well as dedicated leadership. So each place was asked in November to rate themselves against these principles so that we had a kind of bit of a stock take. Basically, the summary of that is that there's areas of really good practice that's going on across the ICB, but equally no area has got this kind of completely sorted. There's wide variation across all the different principles within places and gaps, basically. So if we were to look at, for example, principle one, which is around how we identify frailty so that then we can intervene. We've got various different tools that you can use for identifying frailty. So, for example, when we set up the Jean Bishop Centre, what we asked primary care to do was to run the Electronic Frailty Index, which it looks at various different indicators of health and markers of ageing, to give somebody a score, to give them at risk of frailty, and then the ones who were had a high at-risk score got referred in, and that's easily run within primary care systems. There's similar ones that can be run from hospital data, and if we could get to a place where those were kind of on a overarching registry, and where we were also able to validate them at kind of an every contact counts type thing, and diagnose frailty, then we would be able to make sure that we're getting the right people into the right assessment and services. So for the pre-frail and mildly frail, we'll be able to look at much more of those preventative measures, make sure that they're getting information on healthy aging, so exercise, nutrition. For the mildly frail, looking again about preventative work on your comorbidities, structured medicines review, and then from a severe frailty, looking more around advanced care planning, and potentially things like deprescribing, and really focusing on what matters to the person and where they want to be cared for. And we know that if we do that, then we can make a difference in terms of both individual outcomes and system outcomes. So that's one of the areas that kind of trying to get to as a place. So how we're trying to do that through the kind of the Centre of Excellence is we've set up clinical network across all the different places. We've got really good engagement and collective buy-in to try and do this, so that we can share what's working well in terms of good practice, what can be adopted by other places, and just share that best practice, hopefully at pace. We're working on a frailty strategy aligned to those 10 principles, but it'll be underpinned by place level delivery framework. And then the other thing that we're really trying to look at is the kind of training and research agenda. So look at how we do linking up with other ageing well centres from a research perspective, as well as doing new and innovative research from within our ICB. And then from a training perspective, look again at how we use our workforce smartly, trying to look at tier 1 frailty training for everybody across health and social care, and how we deliver that. But then also for people delivering more generalist care for frail people, how we can have a bit of a frailty academy and training resources for them across the ICB, but supported by a kind of national team that are used to delivering that. So I think Yvonne was gonna just touch on what the next steps are and the milestones.
So I think with all of this, you can have your plans, and it's that so what difference is it going to make, what impact is it going to have. What I would say is, this is an absolutely, it's a great example of a system piece of work that's clinically led, clinically owned, and is being driven through that lens of placing the patient at the centre. I think the other thing that Anna didn't do is really play down just the exciting developments that are coming out of this. So whilst we've got Jean Bishop as a hub, and adopting those principles, it absolutely speaks to that whole challenge that we've got in that UEC space around admissions avoidance, keeping people well, keeping people at home. The other thing that Anna didn't touch on is the international recognition that we're getting, a number of interests coming in. So it's not just nationally but internationally, which again I think speaks to all of the excellent work that's going on across the ICB. And certainly we've got delegates requesting to come from Singapore to New Zealand, and some of that is just not seen, and I think it's great because it all it promotes and enables us to invest into research and development. But the last thing to touch on is we've got the clinical network, we are moving forward with the delivery. It will support that wider integrated neighbourhood team development, that shift to promote and keep people well. We will be running a conference in October. Nigel will be chairing that on our behalf, Nigel Wells, in terms of medical director for the ICB. So that Frailty Summit is planned for October, and we're just working on the agenda. But we're really, really keen on the so what difference is it going to make for our patients, and sharing all of that good practice, and we're happy to take any questions.
Thanks very much indeed. I mean, I know all I hear is good reports and reviews from what's going on, particularly the Jean Bishop Centre, over the months and years actually. And the question I was going to ask has been answered. I wasn't quite sure how the ICB is working to promote it, you know, extend it, scale it up or whatever. But if we've got Nigel chairing that symposium, then obviously the linkage is in the right place there. So that's answered my question from that point of view. But open to the floor for any other comments. Jane.
Aye, thanks Yvonne, and obviously the UEC is a particular focus at the moment. So in terms of, so you've done the assessment of, you know, what every place is doing and those, you know, the strategy and the 10 principles and good practice, etc. So do we know what well, two questions. One is the gaps and how we're planning to meet the gap. And then secondly, you know, whether we like it or not, our criteria to reside figures are the worst in region, i.e. we've got people in beds who shouldn't be in beds. So I suppose what I'm trying to understand is what tangible improvement it's making, particularly for either getting people out or stopping people going in. So it's to two things. One is where are we in terms of development strategy, and the other is the metrics themselves and how, you know, what do they look like and how we're going to expect to see some improvement going forward, I suppose.
Okay, I'll take that one on if you like. So I think there's quite a lot in that, Jane, and I think for me that's sort of in that UEC space. So this is a centre of excellence that is looking to go further faster, to look at what the gaps are and promote that. This work is absolutely interwoven with the whole admissions avoidance, the no criteria, the palliative and end of life, and it's a really complex landscape. There are no hard metrics aligned as it currently stands to the centre of excellence. We're looking at it through a patient safety lens and clinical leadership lens and getting on and doing that, and the training and research. But it is absolutely integral. It will sit and it will support those wider system challenges and programmes of work, but it's not there to deliver that programme of work. Does that make sense? Because that sits in that whole UEC space from an admissions and discharge. So I recognise the relationship and I recognise the contribution that this Centre of Excellence will have, but we're not asking the Centre of Excellence to deliver on those metrics. Does that make sense?
Okay.
Sarah.
Yeah, thank you. So it's Sarah Coltman-Lovell, the Place Director for York, and I have met a number of you before, and I do remember meeting Dr Anna Folwell at the Jean Bishop Centre many moons ago. But I think just to say, I think the principle of a Centre of Excellence, I think, is about us taking the benefit of places working together, sharing good practice, and making sure that we're moving at the pace of the fastest rather than the slowest. And I think the Centre of Excellence has absolutely done that. It has enabled local places to, send visits off to Jean Bishop to understand and learn how that's working. And I think within, whilst it might not be the role of the Centre of Excellence to measure the outcomes, I think where we are learning how to do that within each of our local places, we are building up the evidence base. It's not easy to do, but clearly we need to continue to build that if we are to build these strong foundations on which to stem the rising tide in future. So certainly with Frailty Hub in York, we've been working with Anna Folwell and the team over in Jean Bishop to deliver those messages and the measures. And it would be helpful actually, I think, for us to share that at the October Summit. Yvonne, in terms of actually, we might not be measuring it through the Centre of Excellence, but we are measuring those impacts in place. For example, how many bed days can you save? How many ambulances can you avoid by having these really well-connected acute and community frailty services in place?
I think also, I don't know whose role it is to make sure that people that can learn from this are learning from it and doing something about it. Because, I mean, it's one thing yourself picking it up, say, in York, taking it on, but there might be other areas that aren't taking it on, and how do we oversee that and push and cajole and
And I think that's what the Centre of Excellence has done in terms of this is the result that we expect to see, but it might be delivered in different ways based on the local community assets. So, for example, in York, we haven't got geriatricians in abundance. We haven't been able to deliver a geriatrician-led model. What we've developed is a multi-agency GP-led model. So there are different ways to do it, and I think that's what the Centre of Excellence has enabled each of our places to do based on those local assets.
Thank you. Any comments? Yeah.
Well, I was just going to add, I mean, I think just to echo that, I think we are consistently working together as a system to understand what works well. We work through the community collab, with Yvonne and colleagues. We work together as place directors, work with our local authorities to have these conversations and identify what works well quickly and what we can expand at scale. And it does look slightly, it may look slightly different in each place, as Sarah's just described. The thing that we need to understand is it having the right impact on the outcomes that we want to achieve? Are we seeing those service level improvements? And I think there are, so I think it's just provide some assurance those joint conversations are taking place. Even though the models may not look exactly the same, but there is more to learn, I think.
Thank you. Any other comments that you would like to make? So, go on, Linda.
I'd just like to say that
Jonathan, I've got my hand up again. I don't. My hand's
you are very small. My eyesight isn't that good, I'm afraid.
Sorry, well, it may be because I'm on the screen.
Shouting. Go on, Stephen.
I can see that Anna has too, but I missed a little bit of. I'm sorry, I just had to do something for a second. I missed a bit of the exchange between Jane and Yvonne. But I just want to the whole point of the Centres of Excellence. But notwithstanding, and there clearly is an issue that the communities that we operate in the ICS are different, and there are different elements to that, and you know, therefore models might be slightly different. But the significant challenge in all of this, particularly in this arena, is what the Jean Bishop Centre does really well is brilliant. It does exactly what we want it to do. It keeps older people out of hospital, living well longer. But it doesn't even do that for all the population that could benefit from that in Hull. So the whole issue here is, the real challenge is, the point of the Centre of Excellence is scaling that up, because we know it works. And I do worry, it's a bit like, if you look at the broader run of community services that we offer in the NHS, across our area, there are 6 different offers. So there has to be a core offer here that delivers the sorts of outcomes that we're seeing. And I know, Wendy, back to your point, there are things in the frailty model in North Yorkshire that you would say are equally as effective. But you know, what we have to get is for the total population in this age group to have any impact on what Jack's been telling us from the data analysis. It's got to operate for our 1.7 million people. And that, I mean, I would say, Jonathan, if that's not what the ICS is for, then I'm not sure what it's for. But it's back, and you've said this a couple of times in your introductory remarks here and there. A lot of these things are not new. But I think the environment now is new, in as much as it is a time bomb, actually. It is a crisis, actually. Unless we scale some of this up, we'll be trying to build those additional hospitals that we can't afford. And my final point is, I didn't quite hear the exchange with Jane. I mean, frankly, if this doesn't make any impact on what Jane was talking about, why would we do it? And why would we invest in it? So I'm assuming that's what we're, you know, what's coming out of this Centre of Excellence should be influencing day-to-day operations and helping us to shift the focus away from hospital into the community. Otherwise, we can't afford to do it. So anyway, again, I'm out of the room, so I hope I'm not being too impassioned and noisy, but just want to make those points. Thank you.
Yeah, but I think joint with the urgency, Stephen, there's also the relationships are different than they've been before, by the people sat around the room and the way they're working together, I think, as well. That's the big difference probably from previous years. I know Wendy wants to come back on one, and I think Anna as well wanted to speak.
I mean, Stephen, I hear what you say, and around the sort of we can't do it 6 times differently and we've got to do this at scale. I think we've got a number of components in our models, our sort of out-of-hospital community models that are consistent if you think about virtual wards, urgent crisis response, etc. So we are building that consistency, but I also think this does link to the community reconfiguration work that we have set off through Grant Thornton. I know we're not allowed to call it that, Karina, anymore, but I can remember the new name. But we, you know, and there's a workshop on the 17th of July, bringing all the partners together to really start to look at actually what would a core offer across our community services or our out-of-hospital space look like. How do we define that and set that out so that we are doing that at scale? We're learning from the fastest, we're learning from the best, and we're sort of implementing that at scale across Humber and North Yorkshire. So it's not a finished product, but there's a programme of work to do that.
Linda, I know you wanted to come in, so I'll bring Linda in, then Anna, I think, and Peter wants to contribute as well. So, Linda.
I was just going to say basically what Stephen's already said, that we need to upscale it. We are trying to upscale it in all. You don't need it in Jean Bishop Centre. You can do that from your practices, and that way you'll be more effective because you're reaching more people. And I'm really excited. I think this is the way we need to go forward. Nobody wants to go into hospital. A lot of people in Hull want to go to the Jean Bishop Centre, but you can't swamp it, otherwise it will fail. But we need to find ways of dealing with them, not in the Jean Bishop Centre, but in the practices.
Thank you. Anna, you want to come back?
Thank you. I just wanted to provide some assurance about, so, you know, there's engagement from all the different places in the clinical network, and then each area's got a slightly different then delivery group at place, but they all do exist. So we'll be able to get feedback from kind of that perspective.
Thank you. Peter.
Thanks, Joe. I'm going to circle back a little bit to some of Jack's provocations around how do you solve all of this. I don't think any of us would think that the way in which services are configured now is optimal. So I think, and Stephen made that point very clearly earlier. But when we listen to the public, the single concern that always comes back to us is one around accessibility, particularly around transport. So I think from this partnership, there are opportunities particularly with our elected member colleagues here, around the mayoral combined authorities, and I'm thinking particularly around I think all of the deals, all 3 devolution deals which cover this area include new powers on transport, but also consolidated local transport settlement. So I think as we head towards the time bomb that's been outlined, there are some opportunities to think differently around our engagement about how can we influence some of those new powers to start to think about how does that then increase access to health and social care in a way which we need it to.
Thank you, Peter. Any more comments? If not, I'll thank you so much for that section. But I turn to Karina to say who else we've got to.
Yes.
On my agenda, I've got the frailty anticipatory care. I've also got age-friendly cities and communities.
Yes,
does that
right.
link in next?
It does.
Yeah.
Yes. So we've got our colleagues Carly and Janet on the screen who have and the presentations just come up in the room for us in relation to talking through the work that they're doing on age-friendly communities from their perspective in North Yorkshire and East Riding.
Yeah. So welcome both, and over to you. I don't know who's going to kick off, Carly or Janet, but over to you.
Thank you. Thank you. Shall I make a start? And yeah. Do I need to share my screen then for the people who are online? I'm just thinking, would that be helpful? If I do
Yes,
that, if I share the presentation.
Yes,
yeah. Okay. If you just bear with me. I will do that. Yeah, so my name's Carly Walker and I work in the public health team at North Yorkshire Council and lead on healthy ageing. So this is just one of the examples of pieces of work that we're doing at the council in response to the massive increase of older people that we have compared to other areas that was very much highlighted by Chris Whitty last year, and also in Jack's presentation that highlighted some of the local issues that we're dealing with. So one of the schemes that we're working on is the Age-Friendly Communities programme, and it's a concept that was developed by the World Health Organization. So it's evidence-based, and they've looked at what works and in local areas to improve outcomes for older people, and it's very much around a holistic approach. So focusing on prevention and those wider determinants that Jack mentioned, looking at the voice of older people, and that the voice of older people are at the heart of everything. We're listening to what they're telling us about any barriers that's preventing them from accessing services or ageing well. So local areas are able to sign up to the UK Network for Age-Friendly Communities to signal their commitment, and then you can sign up to the global network of age-friendly communities, which is the World Health Organization one. So local steering groups operate in areas, and at the moment 2 of our local authorities have signed up to the UK network, so that's North Yorkshire and York, and I know Janet will explain what's happening in East Riding, because they're hopefully about to sign up to it. So it can be a local authority that signs up, it can be a local Age UK, or it can be a town council, so it's very flexible about how it might work in each area. So this is what the framework looks like. So there's 8 domains as part of the Age-Friendly Communities outcomes, and underneath each of these there are a series of standards that areas work towards. And again, it depends on what's coming out of the local engagement that older people are telling us, so you don't need to work on all of these at once. So, for example, if we look at outdoor spaces and buildings, it's looking at, pavements, access to buildings, are there public toilets that people can access? It's how do people go out and about and live their daily lives? Is there suitable housing, age-friendly accommodation for older people? And then in terms of community and health services, looking at what the access to health services is like in that area and looking at the barriers. So, for example, we talked about the barriers around transport. So as I say, you can just choose a few of these to focus on, but the ultimate aim is that you'll have everything in place eventually. So this is just what we're doing in North Yorkshire. So we signed up to the UK Network of Age-Friendly Communities in 2019. We're the first rural area to do so. We set up a network of older people to embed the voice of older people into everything that we do. So we've done loads of engagement just to find out what's important, and we've had 4 priorities that have been signed off by our council's management board. We're a new council, and we're embedding healthy ageing and age-friendly across the council, and there's a range of programmes that are being run to try and improve outcomes for older people. And then this year, Louise Wallace's Director of Public Health annual report is going to focus on healthy ageing. So that's very much going to have a lens on our population for North Yorkshire and what more we need to do. And these are just some quotes that we got from older people when we were doing the engagement. I'll pass over to Janet.
I'll get myself off mute. Hello everybody, I'm Janet Smith. I'm Public Health Lead for Older People for East Riding Yorkshire Council. So in East Riding, this is like what we've been doing probably over the last 18 months. We're sort of quite well into the first stage of the programme cycle. We have a steering group, we did an introductory workshop last year. We've been trying to incorporate a systems thinking approach around this. I have some colleagues who specialise in this. Just to help us look at what we've got already, what the connections are, help us identify projects and work that we could do moving forward. One of the things that's recommended is to create a baseline profile. So we did develop a healthy ageing intelligence document for our JSNA in about 2018. So this has been a good opportunity to refresh that data that we have. We have established and update all that, but also we've been looking at going to different partners on our steering group, asking them for what they've got that might, good projects and activities, things that sit under those 8 domains. What's the good practice that we've got, and to help us identify what more we need to work on. Those 8 domains do sit quite neatly with different partners and stakeholders, so it's quite helpful to actually help us establish who we should be getting involved. in May, so last month, we took a paper to the Health and Wellbeing Board to request approval. So the political buy-in is really important for us to take forward, continue to work and take forward the approach. So that's now allows me to put in the application for our national network, supported by the Centre for Ageing Better. And then we plan to follow, so there's a process then to sign up for the global network. So we're looking towards that in the future when we're more established. We're reconvening our steering group just to update, and then looking to move into the next stage, sort of that planning what we'll do, looking at work, sharing the evidence, seeing what projects we can take forward. Thank you. So Carl has provided us with some information about what's happening in York. Obviously this is the work from York. So also kind of these various different steps that they've taken forward. They've had their approval, they've done their baseline assessment, working around those different domains that are important to people. Co-production is a really important element of age-friendly communities, actually hearing those voices of people in communities. So they've got a co-produced action plan that's been signed off by their Ageing Well Partnership, and their steering group meetings are co-produced every other month, so to keep getting that voice feeding in through to the work that they're doing. Partnership with Health Watch York to support that. And I think something great they have in terms of health ambassadors, so people from the community who are ambassadors to bring forward those health issues. So finally, just on to the next slide. So we were asked to consider, what could we all be doing around this? So the three local authority areas that we've mentioned, we're all at different places currently with the work that we're doing on this, to look at areas that have yet to sign up. Are they going through the process? Are there healthy ageing leads who have capacity to work on this to take this forward? So have a look into that, and connect in with the partnerships if they're not already involved. Again, the co-production, are all the people informing and shaping provision in places. There's quite a range of good practice around this. So evidence from age-friendly cities and communities, but I think across other system organisations as well. Are services age-friendly? Are they easy to access? How are they publicised? So lots and lots of things have gone digital, and that's great for some people, but thinking about how do we keep that age-friendly as well. Organisations can sign up to be an age-friendly employer, so East Riding Yorkshire Council has taken this pledge as well. Under our Live Well, Work Well, Health and Wellbeing at Work, there's a number of things that we're promoting around healthy ageing. And people often say to me, kind of looking at healthy ageing, really a life course approach. So thinking about 30s, 40s, 50s, beyond, not just people who are 60s, 70s. So looking at how we can plan and think about the future. So there's training available, some really good established work from other places. I know Leeds, Torbay and Sheffield. So they've been signed up for many years and have some amazing good practice things to learn from. And there is a range of sessions that we can all sign up to. The Centre for Ageing Better also have a positive images library. So this is great, really positive images of older people that can be used, any sort of like reports, things like that. And I guess as of course, considering the recommendations from the report as has been talked about earlier. Thank you.
Thank you very much indeed. I'm just conscious that we need to share this information across all the places and all the local authorities that may be not signed up at the moment, and I'm sure we can do that through our contacts and mechanisms. And thanks for those presentations. And I say we want to just scratch the surface in the last 3 sessions on things we can start doing on the preventative side. I know there's a long way to go, but some excellent examples there. So I don't know, Karina, is anybody else contributing, or is that it for this afternoon?
So that was it for this afternoon. I think from our perspective, obviously there's some real connections with the conversation that most of us in this room were in this morning, and the update that Charlie Jeffrey gave earlier around the work that we're doing with the futures, which is how some of this has come about. it's also a follow-on from the symposium that we had a month or so ago, where 2 months ago I think it was now actually, where we focused on that ageing agenda. So I think it just demonstrates that it isn't something that we aren't focused on as a system, but there is probably some things that we need to connect up collectively. But that there is some great work, and sharing that learning is a really great opportunity here, and it spans both our local government colleagues in this room and the health agenda as well.
Thank you. So thanks very much, everybody, for those contributions, and I'm sure it won't be the last time we see you around in this room moving forward. So thank you so much for that. Thank you. Right, conscious of time, and I know how our chair is keen that we'll always finish on time, so the next short item 40, is on transport and travel, and is down to me, so I shall make it as brief as possible, just setting the scene for Can I first of all ask, Gary, are you in a position to comment as well on this, if I do a little introduction?
Yeah,
brilliant, thank you. Just to set the scene, over many, when I first became a councillor about 20 odd years ago, one of the first ward issues I had was bus connections between the village of Langtoft and Driffield. So now Langtoft is about 6 or 7 miles outside Driffield. It had one bus into Driffield a day, and half an hour later a bus coming back. So if ever you wanted to go into Driffield and you were elderly and couldn't move, you had half an hour to do whatever you wanted to do. And I always remember that as the first ever ward issue I did. And we got in touch with, in those days, Peter Shipp, who ran East Yorkshire Motor Services, and he changed the timetable so people could spend 2 hours in Driffield, and problem solved. But that was really the start of an interest in transport. And one of my close colleagues as a councillor, who stood down last May, has spent many years on the community transport side. And over the years, I think it's become such a complicated area. It's almost one of those wicked issues nobody can tackle, because I remember again in those early days, you had a community minibus and you might fund it. I remember the Millennium bus in Nafferton. It was one bus funded on a short term. When it broke down, it got absolutely, it never got repaired. But suddenly, over probably the last 15 years, first of all, the community and voluntary sector providing community transport has become exceedingly professional. And I quote from what started off as a small organisation in East Riding, the Holderness Area Rural Transport, HART it's called. It now has, and I've got the update, 14 vehicles, 15 paid staff, 11 volunteer drivers, and is a professional organisation, along with 2 or 3 other groups, like Google Go Far, Beverley Lift and others. And that's being parochial. We then talk about NHS connection. We talk about patient transport and the ambulance services, which tend, from my perspective, be very specific to moving patients from one hospital to another. Then we have short-term contracts for Medibus contracts and bits and pieces. So people are scrabbling all the time for short-term contracts to keep some of these organisations going. I think over the last few months, various discussions, we decided access and transport, and tied in with issues, particularly, a lot of it's anecdotal. If you're in Bridlington, it can take 3 hours to get to a urology appointment in Malton. It's just an example. There are no toilets en route, and if you haven't got transport, it takes 3 hours. So people don't turn up for their appointments. So it's wasting money and saving time. And little things have been done to overcome that with short-term contracts to move people around. Now, that's just an example, but I think because we've got the size of the ICS area, it's one of those problems I don't think you can really tackle it. I don't know how you tackle it, but I just feel there is something that needs doing to work and collate and collect, all these various bits and pieces around transport. I know Gary, I think, is doing some work through the VCSE under Jason Stamp as well, pulling together a mapping exercise. But we just thought, rather than just at this point just raise the issue, it's something we feel that we should bring to the September meeting in a bit more detail about how we can maybe move forward the whole transport discussion and debate a bit further, rather than just talking about it, sporadically year on year as we do. So Gary, you might like to, you probably know more about what you're doing than I do.
Hopefully, or a little bit, yeah. So for us, we speak to community transport organisations regularly as part of the VCSE sector. I think we have frustrations, challenges with within the NHS around how do we get people to health appointments, etc. And also you see similar frustration, or equal frustration, should we say, from community transport organisations that are trying to connect in with health, and quite often it's a little bit around communication, but actually a lack of understanding of the community transport picture and what actually is available, I think, to the system. So we've done lots of conversations, webinars and bits and pieces, but we're currently doing a mapping exercise of all of the community transport organisations. The first layer is fairly easy. We know where they all are, and I think colleagues in this room probably know where they all are. The bit that we don't really know is who's eligible for their transport, because everything's different across the whole ICS and different organisations. That depends where their funding comes from. We also don't really know who funds them. To a degree we do, but not fully. And we also don't really understand the number of journeys that those community transport organisations do, but for what purpose. Because I would almost argue that 90% of their journeys is health and wellbeing focused, whether that's GP appointments or whether that's some of the prevention work that we do. And there seems to be a real opportunity to be able to link up NHS colleagues, local authority colleagues with community transport, so that we can make that, how do people access hospital appointments, how do people access health and wellbeing activities better, but we needed to start with this mapping piece. So it's underway now, and we've got a collaborative of 3 community transport organisations leading on this piece of work for us. With a little bit of luck, we should have that finished by September, by the next ICP meeting, so we'll be able to bring something forward to that meeting. And I suspect there might be a number of questions or challenges as well for this group to chew over as well, in terms of how we move it forward.
Thank you. So what we're doing, just setting the scene that it's a piece of work we felt was valuable and would like to move forward, make people aware. No more than that at this stage. So thanks very much, Gary. So we then move on to any other business which you didn't receive, Sue, and I'll hand back to you for any closing remarks.
Thank you. Just on that topic of patient transport, if there's anything you'd like to see, a burning issue for you or an example of good practice, contribute in, you could do that by getting in touch with me or Karina or Nikki. Just so, if you want to contribute, please do. There were no matters of any other business for anyone else, but I am going to slip my matter in again, which is the AGM. So you got it at the beginning and now you're getting it at the end. This is on the 10th of July at 5 o'clock in the afternoon. It's a film version of the AGM, and I hope you very much you'll watch. And that brings our meeting to a close. The next time this group meets will be the 25th of September at 2 o'clock. And it's very likely that we'll be meeting in our new boardroom at Willoughby. We'll no longer be coming here, so we'll be in our own meeting venue, which we look forward to enormously. So thank you all very much indeed. For those of you who've been here all day, it's been a long day. Well done all, and see you soon.
Thank you.
Thank you.